As the moderator already introduced about myself, I'm Dr. Trang, head of neurointervention unit in Thống Nhất Hospital, and it's my honor today. It's my honor to be here today to talk about emergent stenting in AIS, should or should not. So I think all of us already know that stroke is the leading cause of the disability and death all over the world. And the IVT as well as the MT mechanical thrombectomy is classified as the class 1A due to the AHA and ASA. But in some cases of failed recanalizations despite modern mechanical thrombectomy, what should we do for the patients? Stopping with the TC0 or doing something else. And in some situations, the intracranial rescue stenting may be beneficial. However, the outcomes and complications of AS related to the natural history of ongoing emergence like visual occlusions are still unknown. So let's go what's in the guideline. Due to the AHA and ASA guideline, the 2021 guidelines for the prevention of stroke in patients with stroke and transient ischemic attack, it said that the stenting or angioplasty still be class 3. This means harm for the patient. For extracranial carotid stenosis, it's in the class 1A. So, and how about in research? I want to show about 3 large latest research published in the big magazine. First of all, is about the outcomes after intracranial rescue stenting for acute ischemic stroke. The STAR registry is an ongoing prospective observational database of 40 centers in the United States, South America, Europe, and Asia that perform the endovascular therapy in the patients with AIS. And this is also a retrospective analysis was performed to evaluate the outcomes after rescue intracranial stenting using the patient's data from 11 centers in US for STAR. For over 5 years, there was 2,827 patients underwent thrombectomy, of which 120 patients required the RS for failed revascularization. And this research was published on the Stroke Vascular and Interventional Neurology magazine. On patients who underwent intracranial RS failed initial MT, and considerations for the intracranial RS occur in the setting of recalcitrant occlusions due to the variety of causes, including undergoing ICAD, the dissection, the ulcerated blade, intragluminal or mural thrombus, and a poor clot device interface, the resulting in failure of revascularization. And the result is the majority of occlusions in 87 patients were proximal, involving in the intracranial internal carotid artery and M1 segment. Successful reperfusions with TC over 2B was achieved in 85.8% of patients, and symptomatic hemorrhagic transformations occur in 10% of all patients after rescue stenting. This is a figure to compare about the outcome of MRS from 0 to 2 vs the 3 to 6 as 90 days between Mr. Clean, Escape, Door with STAR. And you can see in the A figure, it's a good clinical outcomes seen in 40% of patients undergoing intracranial rescue stenting, compared with only 19% of patients in the control arm of Mr. Clean. In the B figure, in the escape intervention cohort, 54% patients achieved 90-day MRS from 0 to 2, compared with 41% in the STAR cohort. And in the figure C, a total of 27 patients in STAR achieved 90 days MRS from 0 to 2, compared with only 13 patients of the control group in DOR. Let's move to the second research. about the rescue intracranial stenting for acute ischemic stroke after failure of mechanical thrombectomy. And this is a systematic review with a meta-analysis was conducted to examine the effectiveness of rescue stenting after mechanical thrombectomy for acute ischemic stroke, according to the PRISMA. And this research was also published on the Frontiers in the January of 2023. So we can see in the figure B, it shows that the comparisons of stent vs non-stenting in the proportions of patients with 0 to 2 MRS score, and a higher OR indicates a better result of the stenting arm. In this figure, also in B, it shows the comparison of stenting with non-stenting in the proportions of patients developing SICS, and a lower OR indicates a better result for the stenting arm. And the last figure, also in B figure, shows that the comparison of stenting with non-stenting in the proportions of 90 days mortality, and a lower OR indicates a better result for the stenting arm too. So this meta-analysis showed that the RS was effective and safe for the patients with AIS who also have failed the MT, and the result was confirmed as a TSA analysis, showing that the analysis had a sufficient sample size and a statistical power for the MRS outcome. Let's move to the third research. Also the same title is about rescue stenting for failed mechanical thrombectomy in acute ischemic stroke. This is also a systematic review and a meta-analysis, and was published on May 2023 in Stroke, Vascular, and Interventional Neurology. The aim of this research is to compare the safety and efficacy of the rescue stenting with the routine medical management in patients with failed mechanical thrombectomy, and this includes a 12 study including 1,855 participants. There was 729 patients in the RS arm and 1,126 patients in the medical treatment arm. And the result is that the RS was associated with a significant higher proportions of patients with a modified ranking scale score of 0 to 2 at 90 days, a decrease of risk of mortality at 90 days compared with the medical treatment after failed MT, and the rate of successful reperfusions after RS was 87%, and the rate of the symptomatic intracranial hemorrhage did not differ between groups. So we all have a look about the literature. So how about in reality? Let's move to my case reports. The first case is about a male patient, 76 years old. He had the ICAE at the left ICA on October 25th on 2022. But one day after the surgery, at about 6 a.m., he suddenly had the paralysis of the right side. On the CTA before the surgery, in here and the CTA at day 1 post-operation, we can see that the missing of the ICA. We do the rapid, and the rapid answer is the pain number is 124 ml. So we indicated to the patient is indicated for the MT. The lesion in the left CCA. In here we use the neuron smart long sheet to do the image, using the rebar to support the wire going through the lesion in the CCA and check in the ICA for the right way. And then we doing the thrombosection of the M1CA and revascularization at MCA. Then we come back, check backward to the CCA and ICA origin. We assume that it was dissections, and we decided to do stenting through the CCA to the ICA. On the CT scan image on October 27, it means 1 day after the procedure, the contrast used during the MT produced absorbent. Unfortunately, on November the 7th, the CT scan showed that the patient had the intracranial hemorrhage. Then we have to stop using DABT. The CT scan we do on November the 8th, the hemorrhage did not develop. About 1 month later, we keep on, we check again the patients, and then we use the monotherapy of ABT. And this is the CT scan of the February the 20th of 2023. The patient recovered the muscle strength at 3 to 4 per 5. And this is the 9 months later. This is the newest picture of the patients. We can see that the stent from the CCA to the ICA is totally good flow, and the patients can nearly no disability. The case 2 is a 72-year-old man. He admitted in the situations of dizziness and vomiting 30 minutes before. Then he disturbance of consciousness, left hemiplegia, and severe dysphagia. He had a medical history of BA stenosis 11 months ago, but being treated only with aspirin 81 milligram per day. We can see here in the CTA and also the DSA of the BA stenosis. And at the day he admitted to the emergency room, the brain CT scanner showed that there was no hemorrhage lesion, and the CT scanner angiography showed that nearly stenosis occlusion in the BA, but he still have the IV thrombolysis. Then move to the endovascular revascularization. And we can assume that the patients have the stenosis or maybe stenosis, and so we have to decided to use the DABT at the loading dose. Then we do interventions, and you can see here in the pictures is a dissections of the BA. And 4 days after, there was no significant disability. The patients at the MRS1, and 2 months later, the patient fully recovery. Mình không có chạy được cái video này.
Tăng dương tăng mắt. Tôi bị đột quỵ, nhập bệnh viện.
You can say that he can speak very clearly everything, and
ekip bác sĩ điều dưỡng ở viện Thống Nhất đã đặt tên và đưa về khoa nội thần kinh điều trị. Nay tôi khỏe, nay tôi đã đi được, giờ bình thường, ăn uống bình thường, ngủ ngơi được. Thành thật cảm ơn ekip bác sĩ và các.
And in here you can see the patients can work and do everything by himself. There was no significant disability up till now. So in conclusions, the RS is a promising strategy for the maximizing recovery in acute stroke patients after first-line MT fails to achieve the meaningful reperfusions. However, randomized trials using the standardized approach technique and MT failure definitions are warranted to confirm this result. Thank you for your listening.
Questions from the audience? I might have a statement. It'll be up to Vietnam, China, Korea to define what to do intracranial stenosis, because we see them so rarely that all the most important data and the most important studies come from here. So Kung is always one of the speakers who we are inviting to give advice of what to do, because when we run into it, we're always in a mess because we see them so rarely. Questions? There you go.
I have a question for you. You introduced in the second case, the patient come to the ED and and the patient receive an IVT, and so and after that you have decided to in rescue stenting, and the anti-tablet is the APT loading dose. I think it is so risky, and can you tell more about the doses of anti-tablet in that patient with AIS, and we have the decision to put the cranial stenting, rescue stenting for the patient.
Okay, thank you for your questions. Firstly, I want to tell that the procedures to treat the patients with stroke in my hospital is always have the IVT. So when our team approach to the patients, I cannot stop using IVT because the ASA also said that we cannot choose if we want to do the empty, we cannot stop using the IVT, and the neurologist in my hospital always decided to use the IVT in the patients that come to the ER very early, like in these patients. Secondly, for the APT, because we can see that in the DSA very clearly that the patients had dissections in the BA. So we cannot reopen the BA. It's safe using stent. So if we decided to use using stent, we have to use the DABT. But what doses? Because I also cardiologist, so intervention. So I use the clopidogrel at the 300 milligram and the aspirin 325 milligram. After about 30 minutes before doing stenting. And besides, I also use statin too. In this patient, I use the rosuvastatin at 40 milligram. Of course, I also worried about the hemorrhage after the procedure. But in the situations, if we do nothing, we will lose the patient. So I have to ask the patient's family to decide it with me very clearly. Is it okay?
Further questions? I think Kung, you had one.
No, not sorry, not atorvastatin, rosuvastatin. 40 milligram. Is the dose for the patient with the cardiac arrest. Yeah. And in the case of atorvastatin, I will use 80 milligram.